two conveners and distinguished guests, ladies and gentlemen. Firstly, I would like to thank NHRI for inviting me to present this topic. And to celebrate 30th anniversary, happy annual anniversary to the NHRI. I'm going, rather than broad and philosophic presentation, I'm going into more detailed topic regarding the payment system reform today. My presentation will as following. Firstly, I will raise the urgency to enhance value of NHI, and then coming to the detail. I think Vice President Chen and also Professor Chi already provide some evidence that the National Health Insurance is a very successful program around the world. And according to the WHO framework, that the objective of health system are health improvement, responsiveness, financial protection, efficiency, and equity. I think there are lots of evidence showing that Taiwan has been achieved all this goal. And the reason I want to emphasize the value is all of those goals, and also as pointed out by Professor Chi, the final goal is to improve the well-being of the whole society. And health system value is the contribution of the system to the societal well-being. So rather than look into all those goals, I would like to emphasize the improvement and enhancing of the value of national health insurance in the future. After 30 years, why national health insurance should shift from medical service provision to value enhancing. Firstly, the current payment systems should align to health system objectives, but not what the services provided. So the question is, do we provide the right incentive for the provider? And the value of healthcare actually reflects the cost per outcome achievement. And 30 years ago, if we talk about quality or value, then Professor Shi sit here, we asked me, how do you measure all of them? But because of the development of evidence-based effective value of care or low value care indicators that make the measurement of quality and value of care possible, and it enable the design of pay-for-performance, which we already have, and also the value-based payment. The pay-for-performance actually align the payment incentive to the quality agenda based on the best available clinical evidence. And the value-based payment reward provider based on the achievement of quality as well as the cost saving. So that's why after 30 years of endeavor that we have, I would want to emphasize the value today. And the urgency to enhance value care is highlighted by population aging, growth in people with complex mobility and need, technology access investment, increase in the citizen expectation, rapidly increasing health spending, and also the economic impact post-COVID-19. And this is the basic payment scheme of national health insurance in Taiwan. On the top, we have on the macro strategies, we have the global budget to control the cost and provide the incentive for the provider to reform the whole systems. So for the micro strategy, we try to reform the unit of payment to shift away from fee-for-services and to adjust level of payment and introduce certain other measurement such as P4P or use technology assessment to reform the benefit package. So we can achieve the efficiency, quality, effectiveness score as well as to enhance the value. So this is the dream that we used to have when we built up the national health insurance. And this provides an overview of our progress. And before national health insurance, fee-for-service, at that time, fee-for-service is the predominant payment scheme without global budget. So at that time, cost increased 16% per year. After we have national health insurance, before we have the global budget payment systems, the cost still increased around 11% per year. And in year 2002, we incorporate all the sector, medical sector into the global budget. So after that, the average increase per year for the global budget, you can see the red one here. This is the average increase on the global budget, and the average is around 4.1%. It's actually greater than the number of point growth. In Taiwan, we use point system to reflect the relative weight of the health services. And under that, the major payment system still to be dominated by the fee-for-service system. We do have some DRG payment system for some case, and we also introduced some pilot project for the capitation. There are other payment adjustment and initiatives, including we set up a drug expenditure target. Price we adjust down to reflect the overrun on target. Besides, we have pay-for-performance program to cover basically all the prevention and also the chronic disease. And we introduced the family physician initiative, home care, integrate medical care, as well as the hospital at home. The last but not the least, for the pharmaceutical product, in order to speed up the coverage of innovative drugs, we introduced the horizontal scanning, managed entry agreement, and also established cancer drug fund this year to speed up the coverage. So as Vice President Chen already raised that we spend relative less cost on the health care. Right now, the health expenditure share of GDP is around 7.8%, which is a little bit lower than the OECD country. If we make the projection based on the regression line of our per capita income and health expenditure, the number may be up to 9 to 10%, which would be more comparable with the OECD country, which means that we may spend more according to our national income. And in the following section, I'm going to discuss about what we can do in the future to enhance the value of money. And for the current system, as I say, that the fee-for-services is still the predominant more of the payment. It's individual provider actually lack the financial and quality accountability. So the incentive is to provide more services, not necessarily improve outcome of the care. We do adjust fee schedule. However, the adjustment is irregular and may or may not reflect the medical price index. So the level of payment actually are quite low because many hospitals use the point system of the NHRI to determine the salary. So that's why that the provider always complain they have low payment from the hospitals. Besides, we have inequitable payment among specialties. So that have great impact on the physician specialty selection and unequal profit between outpatient and inpatient, medical care and pharmaceutical product. And so the incentive is to increase OPD volume, prescribing more tests and medication with high profit. And also the low hospitalization and nursing fee had great impact on the nurse supply. And the last one is we have the very comprehensive benefit package. It is not affordable in the long run, particularly when we're facing the age of society. The second issue is unit of payment. Most OECD countries right now adopt either DRG-based payment or DRG-based budgeting. As you can see from this slide, that many countries already adopt the DRG system, or some countries with prospective global budget also introduced the DRG-based budgeting systems like Sweden. However, in Taiwan, we are probably the first country in Asia to introduce DRG. Our goal is to introduce DRG to cover all the inpatient costs since we had at the beginning of the national health insurance. However, right now it's only accounting about 22% of the inpatient cost. Although the introduction of the DRG could provide efficiency and effectiveness, and because of the resistance of the provider, it's actually quite slow. And recently, we established the hospital global budget to solve the low conversion factor. However, it's unfair and may have adverse selection problem. So the incentive to reduce volume of patient and not necessarily intensity of the activity in the long run. So because of the time being, I'm going to shift to the last section. And in year 2021, we do have the opportunity to reform the systems and invest the value of care. And that actually, the reform plan actually provides good foundation for Healthy Taiwan project. So back to the main issue we have right now, that the achievement of the enhance of the value, according to HONOR, that there are 3 programs that can enhance the value-based payment. And Taiwan already have those experience. However, we need to speed up the reform so that in the future we can enhance the value of the national health insurance investment. So this is the perspectives for NHRI payment reform. For the unit of payment, I think we should move from fee-for-service to more bundle payment. And for the P4P, right now most of that are single disease. We may move toward multiple disease or even population-based value-based payment because of the aging society with many people have multi-mobility. Besides, primary health care is very important. Currently, we already have the physician initiative. So in the future, we may want to develop integrated program that can, based on the bundle payment and value-based payment, to provide integrated, continuous, and coordinated care in the future. So in conclude my presentation, I think there are several lessons I would like to provide. Three of them I already discussed. And the last one is to introduce the value-based precision benefit package. That is very important for us to increase the value of the national health insurance. We already use this kind of framework to determine the benefit package for the medication. However, in the future, we need to speed up and to cover the medical technology. In conclude my presentation, I think there is no perfect payment system and not one size fits all solution. So in the future, in the payment system reform should align to the achievement of health system objective and not service provision. So to shift away from service, fee-for-service to more bundle and value-based payment is my suggestion. The last one I would like to raise is the fundamental reform on the financing. Financing scheme, benefit scheme are equally crucial to achieve the financial sustainability. And thank you very much for your attention.